My name's Bruce Porter. I'm in the doctoral program at ATSU University, and this is the upper extremity evaluation, assessment, and mobilization for the patient that's been described in our case study, who has limitations of range of motion at her shoulder, pain at the elbow, and also limitations of flexion and extension at the wrist. So we're going to begin our study at the shoulder. Let's move this pillow over if it's all right with you. Move this pillow so I have more room at your shoulder here. And you let me know if you have any discomfort or any concerns. We're going to begin with a anterior glide at the shoulder, placing her in the open pack position here in supine. And we're going to begin with the glide. I'm going to bring this over here like this. Let me know if you have any pain at all. We're beginning with an assessment to see how much range we have, and then we'll move into grade 3 and a grade 4 treatment to increase range of motion. Okay. Looking down. You tell me if you have any pain. Okay. I'm feeling there's the end range right there. So I'm going to move to a grade 3, which is going to be large amplitude movements toward the end range, toward the limitation, which I feel. And this should help, this motion, if we increase this range of motion, this should help with both abduction and flexion of the shoulder, which is what we're shooting for here. Okay, so I'm going to move into grade 4 now, which is at the end range, small amplitude movements, just oscillations, using my whole body weight into the motion like that. Okay. Now we have a limitation of both internal and external rotation at the shoulder. So I'm going to come over. I'm using pretty much the techniques that Dr. Hodges demonstrated for us in the videos, as opposed to the Maitland study. So here we go. We're going to move into this motion here. And again, I'm going to move into an anterior glide as we come into the physiological range of motion limitation. Again, downward force, moving into that limitation physiologically. Good, and we do about 10 oscillations on that side. We'll come back, my foot up here, and we would do the same thing toward the external rotation, come to the physiological limitation that I would feel here, physiologically, volitional movement, and move into grade 3 motions, large amplitude toward the end range, and then finally move into a grade 4. And again, I'm pressuring down, increasing that physiological range of motion as I'm making this motion. Now, this is not the best place to be doing this. We've got about a 90-degree range of motion in flexion, which we've already assessed in our quadrant assessment of the patient. So we come up into approximately where that range of motion is limited in flexion. And I'm going to come around here, supporting her as much as I can. I'm going to move into an inferior glide, pressuring this way. And again, let me know if you feel anything that's uncomfortable. So we're pushing down, inferior glide. I'm assessing first to see where that end range is. Are you resisting me?
No.
Try to relax. Okay. Okay, there it is. So I'm going to move large amplitude motions, grade 3, accessory motions, and then moving into grade 4 at the end range, small amplitude motions like this. Now, there was no specific thought that there might be a scapular. We're going to move your head down to this side now, please. Okay, so we've got scapulothoracic limitations, or we're assuming that, or I'm going to assess for that right now, and then we'll treat for it. I need you to roll onto your left side toward me. Okay, I'm going to bring my Again, as Dr. Hodges did, I'm threading my hand through here like this, feeling for that inferior angle of the scapula. Bringing my hand over the other side to the superior ridge and the spine of the scapula, and using the heel of my hand, body motion, I'm moving. Don't help me. Okay. So we're getting a lot of range of motion here. As Dr. Hodges said, in the caudal direction is where we would expect to find limitations usually. I'm going to put a little extra motion there, a grade 3 motion into that. We're going directly to grade 3 and 4 because there's no specific problems with pain. Approximately grade 3 or less is not a significant amount of pain for this kind of a limitation. So we're getting good motion there. I'm pushing caudally here in a grade 3, large amplitude motion, and then at a grade 4 at the very end, tracing with my right hand and using my body weight, I'm getting motion in the caudal direction. Retraction and protraction, as long as we're here, we're going to do that. And again, Dr. Hodges made the point, I think it's a very good one, that this would help the patient to relax a little bit more. And we'll get rotation, the motion that we would have for flexion of the shoulder. Getting that motion. And that's going very well. Okay. Come back over if you would, please. Come back to put your head at the other end of the table. I'm getting good at that. Now, we're going to move on to the elbow. We're going to have 3 motions at the elbow. I would try to do this in sitting if I could. Dr. Hodges demonstrated for the anterior glide, doing it in prone, and I think that pictures that showed in the Maitland book were more appropriate to do it in the position of without the wedge and just in supine rather than in prone. This, I do need that pillow though. Place this pillow right here. Okay. Now we have pain here, so we're going to move into grade 1 and 2 motions rather than the 3 and 4 that we were doing at the shoulder and that we'll do here, because pain is the limiting factor here. We haven't really demonstrated that, but of course I would be a lot more careful if my patient was truly in that level of pain. 7 to 8 pain is, I consider to be very significant. So I'm going to use the lumbricals of my fingers, particularly on the ulna, to create that motion, gentle, in assessment first, of course, paying specific attention to what my patient has given me in terms of feedback, and I'm sure that would be clear at this point. Pulling here, trying to use my whole body to create that motion, and then we would move into strictly a grade 2. As Dr. Hodges said, clinically, grade 1 is not relevant, so we'd move into grade 2. I do a lot of oscillations on this to try to relieve pain. And then, as Maitland showed, I think it would be appropriate to do glide in the other direction like this. I did practice this. So moving in this direction again, particularly on the ulna. Am I hurting you?
No.
Oh, moving, jumping. Okay. So we're getting grade 2 motions there against the ulna, supporting the elbows in the pain-free position as much as we can. The third point that I think Dr. Hodges made very specifically was pronation supination. Even though there's no mention of it in our case study, I think that pronation supination would be directly helpful for this case, and we would do it with compression, as Dr. Hodges suggested. So we'd put a little pressure inward, what she called axial load, do supination, pronation, and I would be very aware of what my patient's feedback is on this. If the patient is giving me any kind of demonstration of pain or statements about pain, we would reduce the physiological motion regarding how much supination, pronation we would do right there. All right, now remaining in the supine position, moving down to the wrist. I'm going to come over here. Again, this requires a lot of thumb motion, which is hard for me to do, but I'll try to maintain it. We're going to come here most proximally up to the radius and ulna. That's the concave portion. As Dr. Hodges said, we move concave on the proximal end, both here and at the carpal-metacarpal joints. So we're here at the proximal joint, and she suggested a lot of extension as we do this, and I'm applying a little bit of pressure on the carpal bones to try to get motion there while I'm doing extension physiologically. Okay, looking for feedback from my patient as well. I'll do the same thing here. Okay. Now, we're going to move up, and we're going to move distally to the carpal-metacarpal joints, which again, concave is on the proximal side of that articulation. I'm going to move here, do the same kind of motion here. Here, we're distal at this articulation as well, trying to get motion here. And then Dr. Hodges talked. I think it was a very good point that the articulations between the carpals can all be moved, and would contribute to limitations in range of motion. So trying to get motions here in the lunae. Try to increase those range of motions, and you can do that on the dorsal side as well. Okay, those are my motions on the wrist. So that's the end of my presentation. I have nothing more to say. Thank you very much. Thank you, baby.